السلام عليكم. هنبدأ السيشن الأولانية. The first symposium goes to the vitreoretinal surgery part 1. I will invite Professor Amira Abdelazim to give her first presentation.
Bismillah ar-Rahman ar-Rahim. My subject is neuro-ophthalmic manifestations of mitochondrial disorders. The discovery that defects in the mitochondria and mitochondrial DNA could cause human disease has led to the development of a rapidly expanding group of disorders known as mitochondrial disorders. Mitochondrial disorders are more common than was previously thought. The prevalence of mitochondrial disease is about 1 to 8,500. They are so named because of the common feature of impaired mitochondrial function. The main function of the mitochondrion is to produce energy for the cell in the form of ATP. ATP is generated by the respiratory chain, a series of complex proteins that are located in the mitochondrial membrane and are encoded for by both the mitochondrial and nuclear genome. As you see here, we have complex 1, 2, 3, 4, and 5. All are encoded by mitochondrial and nuclear genomes except complex 2, which is only encoded by nuclear DNA. Consequently, mitochondrial disease can be caused by mutations in either mitochondrial or nuclear DNA. So in the offspring cell, we have the mitochondria. The mitochondria in the offspring cells comes only from the mother, but the nuclear DNA is shared from the mother and the father. The clinical presentation of mitochondrial disease can be highly variable. Some mitochondrial disorders only affect a single organ, for example, the eye, as in Leber's hereditary optic neuropathy. Professor Dr. Zainab Osman will explain the Leber's hereditary optic neuropathy in the next lecture. But the mitochondrial disorders may involve also multiple organ systems and often present with prominent neurologic and myopathic features. Mitochondrial disorders may present at any age. Many affected individuals display a cluster of clinical features that fall into a discrete clinical syndrome, such as chronic progressive external ophthalmoplegia. As you see here, the affected child has external ophthalmoplegia, bilateral ptosis, and mild myopathy. Also, Kearns-Sayre syndrome, which is consisted of chronic progressive external ophthalmoplegia, bilateral atypical pigmentary retinopathy, cardiac conduction abnormalities, and short stature. Mitochondrial encephalomyopathy with lactic acidosis. We have also this syndrome, which is also associated with stroke-like episodes. It's called MELAS. MELAS syndrome can have pigmentary retinopathy. Myoclonic epilepsy with ragged red fibers, which is called MERV syndrome. MERV has ataxia, cerebellar ataxia, and it may have optic atrophy. Ragged red fibers means collection of diseased mitochondria. Diseased mitochondria makes clumps, which is collected under the sarcolemma of the muscle fibers, and when stained with certain stain, it makes the fibers looks like ragged red. Neuropathy, ataxia, and retinitis pigmentosa. It's called NARP or Leigh syndrome. However, considerable clinical variability exists, and many individuals don't fit neatly into one particular category. So, the common neuro-ophthalmic features of mitochondrial disorders include ptosis, external ophthalmoplegia, optic atrophy, and pigmentary retinopathy. The common central nervous system findings include fluctuating encephalopathy, seizures, dementia, migraine, stroke-like episodes, ataxia, and spasticity. The mitochondrial disorders also have other manifestations like proximal myopathy, exercise intolerance, cardiomyopathy, sensorineural deafness, diabetes mellitus, renal tubular defects, and liver failure. As we see that the mitochondria affects the most active parts of the body, like the muscles and the nervous system, which these parts needs the energy from the ATP formation. Diagnosis of mitochondrial disorders is often considered in children with complex neurological picture or single neurologic symptom and other system involvement. When the presentation is classic for a maternally inherited mitochondrial syndrome, such as MELAS, MERF, or LON, appropriate mitochondrial studies should be obtained first. When the clinical picture is non-specific but highly suggestive of mitochondrial disorder, the clinician should start with measurement of plasma CSF lactic acid concentration and ketone bodies, plasma acyl carnitines for fatty acid oxidation, or urinary organic acids for exclusion of uremias, organic uremias. If these studies are abnormal, the clinician should proceed with muscle biopsy and respiratory chain enzymes. Here is the low power and high power picture of ragged red fibers. The neuroimaging studies also are important. The CT may show basal ganglion calcification, as we see, and the MRI may show focal atrophy of the cortex or cerebellum. There may also be evidence of generalized leukoencephalopathy. Here we have abnormal signals of the basal ganglia, and here we have changes in the white matter and symmetrical abnormalities in the signal in the butamins in both hemispheres. The neurophysiologic studies in cases of encephalopathy or seizures, the EEG studies may show in encephalopathy may be, as we see here, encephalopathy may be associated with generalized slow wave activity. However, the seizures have generalized or focal spike and wave discharge. Here we have generalized spike and wave discharge. Electromyography is often normal but may show myopathic features. Nerve conduction velocity may be normal or may show predominantly axonal sensorimotor or polyneuropathy. Magnetic resonance spectroscopy and exercise testing. This is very important to detect and evaluate the lactic acid level in the brain and the muscle at rest. Here we can see the spectroscopy. This is magnetic resonance spectroscopy, shows the two inverted peaks that resembles W at around 1.2 on the horizontal axis. This indicates high lactate concentration. Also, delay in the recovery of ATP peak in the muscle after exercise is important. Magnetic resonance spectroscopy with measurement of blood concentration of lactate may be used to detect evidence of abnormal mitochondrial function non-invasively. Blood lactate concentration is indicated in individuals with features of myopathy or CNS disease. Fasting blood lactate concentration above 3 millimole per liter supports the diagnosis of mitochondrial disease. CSF lactate concentration is indicated in individuals with suspected CNS disease. Fasting CSF lactate concentration above 1.5 millimole per liter supports the diagnosis. Also, fasting blood glucose may indicate diabetes mellitus. Both echocardiography and both electrocardiography and echocardiography also are diagnostic. Respiratory chain complex studies are then usually carried out on the skeletal muscle or skin fibroblasts. The function of each of the 5 proteins of the respiratory chain is tested using certain biochemical reactions. For differential diagnosis, the most important is lactic acidosis. The mode of inheritance of mitochondrial disorders, as we said, that mitochondrial disorders may be caused by defect of either mitochondrial DNA or nuclear DNA. So, the inheritance of the mitochondrial disorders are inherited either mitochondrial DNA defects are transmitted by maternal inheritance. The inheritance patterns of the males, this means that the mother can transmit the disease to all her children. But the males carry the mother's mitochondrial DNA, but only the female pass it to their children. The nuclear gene defects may be inherited either autosomal dominant or autosomal recessive. This is the autosomal recessive inheritance. Both parents are carriers, and 25% of the children, there is chance of 25% of the children to be affected, and chance of 50% of children, 50% chance of the children to be carriers, and 25% chance to be normal. And in autosomal dominant inheritance, one of the parents is affected, and there is 50% chance of the children to be affected, and 50% chance of the children, chance for the children to be normal. Prenatal testing for mitochondrial disorder is important. Mitochondrial DNA mutations can be detected, but it is difficult because of mitochondrial heteroplasmy. Mitochondrial heteroplasmy means that the percentage level of mutant mitochondrial DNA in the chorionic villus sampling biopsy may not reflect the percentage level of mutant mitochondrial DNA in other fetal tissue. Prenatal diagnosis is not recommended except for the mutation of only 2 mutations, because they have more even tissue distribution, and the percentage level of these 2 mutations does not appear to change significantly over time. Prenatal testing can be significantly done by either amniocentesis or chorionic villus sampling. The management of mitochondrial disease is largely supportive. Early diagnosis and treatment of the supportive, like early diagnosis and treatment of diabetes, cardiac pacing, ptosis correction, intraocular lens replacement cataract, and replacement for cataract. Variety of vitamins and cofactors have been used in individuals with mitochondrial disorders. Individuals with complex 1 or 2 deficiency may benefit from oral administrations of riboflavin. The role of exercise therapy in mitochondrial myopathy is currently being evaluated. Coenzyme Q10 is specifically indicated in persons with defect of coenzyme Q10 defects of coenzyme Q10 biosynthesis. Idipinone shows promise for the treatment of Leber's hereditary optic neuropathy. Preventive strategies under investigations. This is very interesting. Under investigations now, they make nuclear transfer. The process involves removing the nucleus from the mother's ovum and transfer it to a donor ovum, in which its nucleus is removed, and then it is fertilized and transferred to the uterus of the mother. So we expect that the child will have two mothers sharing in the child, one with its ovum and the other with its cell. And this is only done this method was done only in the monkeys, and it's succeeded. Thank you very much.
Thank you for your valuable information. We would like to invite Professor Osman to give her presentation.
Mr. Chairman, Co-Chairman, and dear colleagues. Bismillah ar-Rahman ar-Rahim. I will discuss today Leber's hereditary optic neuropathy or Leber's optic atrophy. It is mitochondrial inherited degeneration of retinal ganglion cells and their axons that leads to an acute or subacute loss of central vision. It affects predominantly young adult males. However, LON is only transmitted. However, in spite of it appears predominantly in the young males, it is transmitted through the mother, as Dr. Amira told us. About 100 people in the United States lose central vision due to LON each year, joining the 4,000 or so Americans who are already vision impaired due to LON disease. It's estimated that about 35,000 people worldwide have LON vision. It is not a rare disease. Symptoms onset is usually in young adult males, but age range may range from 7 to 75 years old. The symptom blurring and clouding of vision are usually the first symptoms of this disorder. These vision problems may begin in one eye or simultaneously in both eyes. If vision loss starts in one eye, the other eye is usually affected within several weeks or months. And this condition mainly affects central vision, which is needed for detailed tasks such as driving, reading, and recognizing faces. Signs. The main features are seen in fundus examination, just before or subsequent to the onset of visual loss. And that is why it is important to follow up persons who are liable to develop such a disease in order to discover the disease very early before the onset. The affected eye demonstrates an edematous appearance of nerve fiber layer, especially in the arcuate bundles, and enlarged or telangiectated and tortuous peripapillary vessels, or microangiopathy. A pupillary defect may be visible in the acute stage as well, that's sluggish pupil. Examination also reveals decreased visual acuity, much decreased visual acuity, loss of color vision, red and green, and centrocecal scotoma on visual field examination. LON plus. What we'll discuss here is LON alone. Painless vision loss is typically the only symptom of Leber hereditary optic neuropathy, but Lone plus is a name given to rare strains of disorders with eye disease together with other conditions like tremors, inability, defect in the muscle control, which lead to tremors, hard movement of the muscles, and sometimes cardiac arrhythmia. Cause of Leber hereditary optic neuropathy is a condition related to disorder in the mitochondrial DNA pathophysiology. The eye pathophysiology is limited to the retinal ganglion cell layer, especially in the papillomacular bundle. Degeneration is evident from the retinal ganglion cell bodies to the axonal pathways leading to the lateral geniculate nuclei. Experimental evidence reveals impaired glutamate transport and increased reactive oxygen species, that is to say, reactive oxygen radical, يعني oxidative process, causing apoptosis of retinal ganglion cells or programmed cell death. Now the diagnosis. Without a known family history of Lone, the diagnosis usually requires neuro-ophthalmological evaluation and blood testing for mitochondrial DNA assessment. Prognosis. Although central vision gradually improves in a small percentage of cases, especially who are discovered early and treated early in the disease, in most cases the vision loss is profound and permanent. Over time, vision in both eyes worsens with severe loss of visual acuity and color vision. Treatment. There is beneficial treatment available for some cases of this disease, especially for early onset disease. Also, experimental treatment protocols are in progress. For example, IDB has been shown to have modest benefit in about half of patients. People most likely to respond best were those treated early in the onset of the disease. And that's why follow-up of persons in the same family is very important, and also the carriers. Alpha-tocotrienol quinone, a vitamin E metabolite, as we know all that vitamin E is one of the antioxidants. They found that it had some success in small open-label trials in reversing early onset vision loss. And we have to follow up the patient by regular correcting visual acuity, by genetic counseling, and by checking the visual field every now and then. And we have to prescribe for them vision aids assistance, and work rehabilitation should be used to assist in maintaining employment. Differential diagnosis, toxic and nutritional optic neuropathies, and also multiple sclerosis due to the presence of ataxia, tremors, and some other symptoms and signs. Also, it is important to until time is over, it is important to exclude some other causes of vision loss and accompanied with other diseases such as cardiac arrhythmia or electrical conduction system abnormalities. Monitor the progress. Monitor the progress for carriers. For those who are carriers of Lone mutation, preclinical markers may be used to monitor progress. For example, fundus photography. As we see in the fundus photography, red-green color vision testing, which may be affected. Also, contrast sensitivity may be affected, and electroretinogram and visual evoked potentials may be affected, and therefore we can discover early the carriers who are also susceptible to develop the disease. Advices for carriers: avoiding optic nerve toxins such as tobacco, alcohol, also certain prescription drugs are known to be a potential risk. So all drugs should be treated with suspicion and checked before use by those at risk. For example, ethambutol, which is an anti-tuberculous drug, in particular, has been implicated as triggering visual loss in carriers of Lyme. Also, we have to follow these carriers. When a patient carrying or suffering from Lyme or toxic nutrition optic neuropathy suffers a hypertensive crisis as a possible complication of the disease. So nitroprusside should not be used due to increased risk of optic nerve ischemia in response to this anti-hypertensive in particular. And shukran jazilan.
Thank you, Professor Osman, for your nice presentation. I would like to ask Professor El-Malt to present vitrectomy without internal tamponade in rhegmatogenous retinal detachment.
Mr. Chairman, good morning everyone. I'm going to talk about a technique used in some cases, that I use in some cases of primary retinal detachment, especially with moderate degrees of proliferative vitreoretinopathy, especially with peripheral retinal breaks in the lower circumference of the retina. Despite the advances in vitreoretinal surgery, primary retinal detachment remains a significant cause of visual morbidity. The most commonly used modalities are buckling and pars-planar vitrectomy. The decision to use one of these modalities depends on several factors: the number and location, and also the size of the breaks, the lens status, the available equipment, surgical preferences and skills, and also patient compliance. In order to achieve a successful retinal reattachment, the goal of surgery should be treatment of all retinal breaks and relief of all vitreous traction on the break. Most early surgical failures are also due to inability to achieve one or both of these objectives. So the objective of this technique is to determine the efficacy of combining scleral buckling and vitrectomy without internal tamponading in selected cases of primary rhegmatogenous retinal detachment to achieve a permanent retinal reattachment with one procedure. All patients underwent scleral buckling with segmental, circumferential, and or radial buckles, in addition to a complete triamcinolone-assisted vitrectomy with shaving of the vitreous base and endolaser to the retinal breaks after precise localization. So the steps included, this was supposed to be a video, but I did not upload it on this talk because I have a limited time. The video will be available on the Rio website for anybody who wants to see it. The steps include brittling of the recti muscles first, and then the triple port vitrectomy with the triamcinolone-assisted peeling of the posterior vitreous cortex and shaving of the vitreous base, and shifting then to fluid air exchange. And then we externally localize the anterior and posterior edges of the retinal breaks, placement of a scleral sutures and buckle without tightening, and then go back to air fluid exchange to tighten the globe, and then tighten your buckle, do the endolaser to the buckled retinal breaks, and then close. Patient selection, inclusion criteria included a primary rhegmatogenous retinal detachment, phakics with clear lenses, peripheral breaks generally in the lower circumference of the retina that are amenable to buckling. Exclusion criteria included aphakics and pseudophakics, diabetic retinopathy, penetrating traumas, posterior breaks, giant retinal tears, and also technical difficulties that could be gained with scleral buckling, such as thin scleras, multiple prior strabismus procedures, glaucoma drainage devices, and so on. So the primary outcome measure was the retinal reattachment without any re-operations for at least 6 months. Visual outcomes varied depending on the preoperative visual acuity and whether the macula was detached or not. The duration of macular detachment was inversely proportional to the final visual acuity. Post-operative OCT showed persistent foveal macular detachment in some cases in which the macula was preoperatively detached, and in none of the patients with macular sparing, even if the ophthalmoscopic examination showed the retina to be successfully reattached. This subretinal fluid adds negatively to the post-operative visual acuity. Its resolution is a matter of time, from 2 to 3 months, unless there is new proliferation or epiretinal membrane formation. So the success rate of scleral buckling alone in primary retinal detachment ranges from 73 to 89% in most studies. This percent rises to 96% with an additional surgery after failure of the initial operation. The development of PVR is the primary cause of failure despite multiple interventions. Most complications of scleral buckling include increased degree of myopia and formation of epiretinal membranes. Infrequent complications also include diplopia, cystoid macular edema, choroidal detachment, especially with drainage of the subretinal fluid, vitreous loss during suturing or draining, and choroidal and vitreous hemorrhages. To my mind, a major drawback of scleral buckling surgery alone is that first, the vitreous remains attached to the retinal brakes, giving a chance for further traction and activation of the PVR. And the second is that you have to indent the sclera too much to achieve a high buckle, that is to shorten the distance between the brake and the underlying retinal pigment epithelium. Although primary vitrectomy avoids some of the complications associated with scleral buckling, such as diplopia, choroidal detachment, scleral perforation, eyelid abnormalities, and of course late extrusion and infection, yet it by itself carries a high risk of several other complications, including cataract formation in phakic eyes through several mechanisms, glaucoma, and other problems with tamponade. Removal of the vitreous and intraoperative infusion of fluids produces some measurable changes in the lens, which increases with the age of the patient. The additional use of intravitreal gas or oil increases the risk of measurable changes in the lens, especially in patients older than 50 years. Moreover, in most studies, the primary success rate after vitrectomy with gas or oil tamponade does not exceed 88 to 90%. So there is an area of uncertainty because neither the American Academy nor the Retinal Society has published formal guidelines for selecting the optimal surgical procedure for repair of primary retinal detachment. So from this, the consensus of buckling and vitrectomy without internal tamponade is born to try to minimize the complications of each procedure alone to achieve a higher success rate of reattachment after a single surgical intervention. In this technique, we use a low buckle that can easily achieve an approximation between the retinal pigment epithelium and the retinal brake on which no more traction is exerted. A simple low buckle can bypass much of the complications of high scleral buckles, such as diplopia, increased myopia, suture problems, and also the complications related to external drainage of the subretinal fluid. In addition, vitrectomy relieves all traction exerted on the brakes and elsewhere on the retinal surface, such as in epiretinal membranes, cutting off the vicious circle of PVR with RPE cells, blood, mediators of inflammation, by thorough removal of the vitreous gel and cortex from the anterior retinal surface and the vitreous base. So not using vitreous substitutes such as gas or oil also reduces to a great extent most of the complications accompanying their use, such as cataract and increased intraocular pressure, and also bypasses the problem of inability or inaccessibility of patient positioning. So to conclude, the postplantar vitrectomy with a scleral buckle achieved without internal tamponading achieved noticeable time-dependent dependent successful results in patients with primary retinal detachment, especially with peripheral breaks, as I said, in the lower circumference of the retina. A rationale strategy for repair of primary retinal detachment requires an individualized approach, taking several factors into consideration to achieve single operation success rate and good visual outcomes. Thank you very much.
So thank you very much for your beautiful illustrations. Because of time factor, we would like to ask Professor Ehab Saad to give his speech earlier, because he is committed to another meeting.
Opening presentation. Okay. ده أول هي كده فل عشان بس نسكرول يعني 10 minutes. Okay. Next. هي كده فل.
Mr. Chairman, dear colleagues, I would like to congratulate the Research Institute for the ongoing efforts enhancing the science in ophthalmology. Why is it important to differentiate pediatric age retinal detachment, pediatric age group retinal detachment? Because it's important to identify the exudative component in pediatric age group as a specific pathological entity and differentiate it from rhegmatogenous detachment. Those kids presented in different times. The child here had leukocoria, the girl has leukocoria. The ultrasound is showing retinal detachment. The CT scan is not showing much here, and there is an amalgam or a mass present in the eye of the child. The girl has a similar condition also. The detachment is present. There is an amalgam here. The CT doesn't show much. There is a hyperdense mass within the right eye, and this is the ultrasound. So in the child, we might go ahead for vitrectomy and we might cure vision. In the same kid with the same similar condition, we might go ahead with vitrectomy and we will literally kill the child in 6 months' time. This girl has retinoblastoma, and she opening the globe in an eye harboring retinoblastoma and not identifying the retinoblastoma as retinoblastoma is a malpractice. So this is why we have to keep things in mind, because the long list of differential R retina cases in this review by Shields et al. Back in the 90s, he identified 48% of leukocoria cases referred as retinoblastoma not being retinoblastoma. So the differential is important, and the list is really confusing. This is a case study. This child presented to us at the age of 4 months, boy, poor fix and follow, and he was starting nystagmus. The anterior segment was normal. The right eye showing diffuse vitreous hemorrhage. This is the fundus in the right eye, and this is how the left eye presented, with a retinal detachment, the retina behind the lens, and there's 2 foci within the retina in here, total exudative, extremely thinned out retina behind the lens. While thinking about how to manage the right eye, I continuously thought about how to manage the left eye. What does the child has? And why was the vitreous hemorrhage ensuing in his right eye? Despite a normal bleeding profile, normal CBC, normal ESR, nothing was there. The review, a normal delivery, and nothing was there to indicate a pathological entity, whether in the right eye or in the left eye. So the decision for the right eye was easy, a 23-gauge vitrectomy, and this was done with improvement in vision. What about the left? A huge retinal detachment with the leaves behind the lens. So I did something while doing the vitrectomy out of the box, and this is how the eye looked like 3 weeks after, while proceeding with the procedure. I was thinking about what to do for the left eye. The thought is that these two foci rose the attention of this might be inflammatory, and this is an exudative detachment. So what I did while doing the vitrectomy to the right eye is in injecting periocular triamcinolone, and to the happy surprise, 3 weeks after the retina was totally flat in this eye, doing a procedure, I did some laser peripheral scatter photocoagulation, and that was it. The vision recovered in both eyes, and this is the laser. So the triamcinolone was given peribulbarly 2 milligram, and this was proven to be an inflammatory. Otherwise, if we proceeded to buckling or vitrectomy, this eye would have been lost. So the Coates is another entity we encounter in pediatric age group. It's simply telangiectasia or leaky vessels, as we can see on the fluorescein angiography. It's a congenital non-familial idiopathic vascular developmental disease of the retina, retinal telangiectasia, exudation and detachment, and on fluorescein angiography, we appreciate peripheral vascular ischemia, peripheral ischemia, capillary ischemia. We recently published a BGO paper in 2010 describing 15 cases of Coates disease with visual improvement in the maneuver we are describing now. This is a 4-year-old boy coming with xanthochorea, not leukochorea. He had Coates disease with a CNV sitting in the macular area. This is how he looks like. This is the peripheral ischemia, the telangiectasia and peripheral ischemia noted on fluorescein angiography, on wide-angle fluorescein angiography using the RETCAM. What we do is when the retina is elevated, we inject triamcinolone. Initially it was 40 milligram. This induced cataract. Now we inject 2 milligram. We wait for 3 to 4 weeks. The retina flattens out, and then we perform laser to the retinal peripheral ischemic area. This is how the laser was performed. This case was managed by my colleague, Dr. Magdi Musa, and this is how we save the eye and vision. What about the advanced Coates disease with the retina behind the lens? In those cases, we perform a transscleral drainage of the exudate, and we do not think about going through the vitreous, because this is an exudative retinal detachment as well. The transscleral drainage drain the contents, and this is an intraoperative finding where we inject triamcinolone, and then a month later we perform laser to the periphery of the retina. It goes without saying, when we talk about pediatric retina, we have to mention retinopathy of prematurity, which is a pathological process in the immature retinal tissue that might progress to proliferative retinopathy with potential blindness. This is a serious condition. It's due to the abnormal retinal vasculogenesis. Important notes to remember that the the chronological age of initial examination for those being 27 weeks and above is 4 weeks post-delivery. So the 1 month is a crucial point where we have to go to the pediatric neonatal ICU, to the neonatal ICU, and examine the child if he's not getting out yet. The early treatment ROP trial has defined new risk factors, the type 1 ROP, where the disease is more posterior in zone 1 with plus disease or with stage 3 disease, or zone 2, stage 2 or 3 is mandatory for treatment now. This is a zone 1 disease where the retinal vessels stop abruptly within 4 disc diameter of the optic nerve, and this indicates a severe ischemia. The wait and watch policy is important to identify as well, because this will save many eyes that are treated unnecessarily. We have to remember that the ROP natural history is towards spontaneous regression. This is a case that was going to be treated. This is a child that I saw a few months ago, and the child showed sign of regression. This was the ridge, and the vessels crossed over the ridge, though the eye was a bit angry, and the decision was to follow up the child, and it ended up by regressing spontaneously with the vessels crossing over and reaching the periphery. We have to remember that continuous traction causing macular ectopia in the only seeing eye is necessary, is an indication for surgery. We have to remember the rules of thumb for placing the instruments. From 0 to 6 months, we put the sclerotomy at 1.5 millimeter from the limbus. And this is how we recover the retina and the macular area in the only seeing eye in this child, monophthalmic child. She is myope, but this is how we manage the cases. In advanced stage 5 ROP, we proceed with lensectomy, vitrectomy, and we sometimes end up by having good results, good anatomical results, though poor functional results. Amblyopia management is important. These are the two eyes of a child, one advanced eye, and the other eye is the retina is totally engulfed within the vitreous. So we proceed here with pars plana lensectomy, vitrectomy, and we have to identify the stalk within the stalk emanating from the optic nerve, and to exert every effort to remove that stalk from up to the optic nerve to get good anatomical and hopefully functional results. We use the bimanual dissection, and as you see here, the extension is up to the optic nerve. And we could successfully identify and isolate those extensive fibrosis, ending up by flattening of the retina within a 6-month period and recovery of some vision. A little vision is better than no vision in those cases. Another case with marked improvement and flattening of the retina within a 6-month period. We use Avastin only in zone 1, posterior or posterior zone 2, and we also published the results of the effect, marvelous effect of decompression of the Avastin. We augment this with indirect laser photocoagulation to the retinal periphery as well. So the conditions necessitating intervention in those stages retinopathy in those pediatric conditions might need to sit back and think about how to manage and think about how to diagnose, and this is important, and this is, I think, is another subspecialty within the retina in those particular and peculiar cases. Thank you very much for the attention.
Thank you very much, Dr. Saad, for your beautiful message. And I would like to invite Professor Schumann to give his lecture.
Dear professors and colleagues, good morning. My talk will be about the visualizing aids in macular surgery, what we do to enhance our visualization. Visualization aids has been used now for almost a decade or more to enhance the visualization of ILM and the epiretinal membrane with a lot of success and a little defects regarding the toxicity. There are a lot of pros and cons to the different types of dyes that we are using, or the agents, which we are going to discuss in these presentations. The dyes that we are usually using are indocyanine green and the triamcinolone acetinoid and trypan blue. Indocyanine green is a fluorescent cyanine dye which binds to plasma proteins, and it was used mainly or introduced as an additional dye to fluorescein, and it has been used one of the earliest dyes to enhance the visualization of ILM and epiretinal membranes. This is a picture of the ILM peeling with the maximum visualization and enhancement, one of the best dyes. And it has been injected usually, or proposed to be injected.
في منهم لا دي طويلة مش هقدر الاقي الحتة دي. طب هو اصلا كان موجودة كلها؟ لا لا دي مقطوعة، مقطوعة فين القطعة اللي موجودة؟ مش عارف ايه ما بتسألش بس مش عارف. انا مشغلة هنا احنا بنجيب الأسفل مسلمين. هم دول كلهم. مش متعرف على القرآن؟ هل هو مش متعرف؟ مش يبقى اللي هو اللي معمول عليه يعني الأستاذ بيقول إنها معمولة على 2010 ودي 2010. دي 2010 نعملها على 2003 2007 2012 كده؟ ممكن. هي مش قارية غير أوديو بس مش فيديو. طب نقدم اللي بعد مثلا ونعملها احنا ولا مفيش مشكلة؟ ممكن نحلها. ممكن نحلها. ممكن احنا نشفت النكست ونحل المشكلة دي بعدين. في حاجة في الصور عندي. نكست give me next.
We proceed with the next one? Should we proceed with the next one? Next speaker?
Okay. We'll solve it. Okay.
So I would like to call Professor El-Agha to present his intravitreal anti-VEGF laser versus laser alone for stage 3 ROP.
Members of the panel, my dear colleagues, good morning to you. I'd like to congratulate the organizing committee on such an elegant meeting, and I'd like to thank the organizing committee for the invitation to speak at the meeting. My talk today is on a study looking at the role of bevacizumab in retinopathy of prematurity, and we know that the standard of care up until quite recently in threshold ROP was indirect laser photocoagulation, and this was indicated in patients with zone 1 disease with plus disease, regardless of the stage, patients with zone 1 disease and stage 3 even without plus disease, and zone 2 with plus disease, either stage 2 or stage 3. Laser photocoagulation has historically been very, very successful. The overall success rate of laser is 92 to 95%, but of course there are limitations. The success rate in zone 1 disease is almost half of that, about 50%, and laser may be precluded by vitreous hemorrhage or a persistent tunica vasculosa and poor general condition. And hence it became, this was the rationale of using bevacizumab, that retinal neovascularization in ROP is VEGF dependent, that patients with zone 1 disease probably have a VEGF load that is beyond the efficacy of laser, and that laser itself disrupts retinal cells, further releasing VEGF. And the thought was that if we add bevacizumab to laser, this may have an additive effect in inhibiting neovascularization. And our study is a prospective controlled interventional fellow eye study that was done to determine the effect of adding intravitreal bevacizumab to conventional laser photocoagulation in stage 3 retinopathy of prematurity. The primary outcome measures were resolution of neovascularization and the occurrence of retinal detachment, and the secondary outcomes were considered to be the speed of resolution of plus disease and the intensity of the psychotrucial response. We had the inclusion criteria was stage 3 ROP with plus disease and zone 1 or posterior zone 2 disease. And in one eye, we did just the indirect diode laser photocoagulation, which is the conventional treatment. And in the fellow eye of the same patient, we did laser with the addition of intravitreal bevacizumab, 0.625 milligrams in 0.025 milliliters. And we had 15 patients, that is 30 eyes, that met the study criteria. When we look at the demographics, 60% were females. The mean gestational age was 29 weeks. The mean birth weight was 1,260 grams. And we'll notice that about half of the patients were part of a multiple pregnancy, either twins, triplets, or quadruplets, which is, of course, a very common cause of premature birth. This was the post-menstrual age at intervention, ranging from 34 to 38 weeks. And we identified 4 response patterns. We either had complete resolution with regression of plus disease, regression of peripheral new vessels, no fibrous membranes, and no traction. So this was the best scenario possible. In some cases, we had resolution with fibrous tissue formation, but without traction. In some cases, there was resolution with fibrous tissue and traction. And in a 4th group of cases, there was incomplete resolution with a need for reintervention. So this is an example of complete resolution. And this is an example with laser pointed. We'll notice here that in the top part of the photo there is some traction that has, that there's some fibrous tissue that has formed without traction. And in this case, we have traction, fibrous tissue that has developed and has led to traction, but there is no retinal detachment. So you might get some dragging of the retina, but without actual retinal detachment. And finally, we had cases where there was persistent neovascularization that needed reintervention. You can see that there is still persistent new vessels in this area. And when we look at the response pattern by group, we'll notice that on the left, in the laser bevacizumab group, we had complete resolution in 13 cases versus 10 cases in the laser group. Resolution with fibrous tissue formation but no traction occurred in 1 patient in both groups, and resolution with fibrous tissue formation and traction also occurred in one eye in each group. And we'll notice that persistent neovascularization was noticed only in the laser group, which shows that with the addition of bevacizumab, we had almost complete resolution versus about 80% in the laser-only group. What was also noticed that the time of resolution of plus disease was 2 to 5 days in the laser bevacizumab group, where it was significantly longer in the laser-only group, 8 to 15 days. So this was another point in favor of adding bevacizumab. The cases that required reintervention were 3 cases in the laser group that had persistence of neovascularization for more than 1 week. And in these cases, we injected bevacizumab again, and we added more laser. And we had eventual resolution of neovascularization with fibrous tissue formation and retinal dragging, but without retinal detachment in all cases. So the addition of intravitreal bevacizumab to laser photocoagulation in stage 3 ROP resulted in faster resolution of plus disease, more complete resolution of neovascularization, and there was less need for secondary intervention without exaggeration of the cicatricial response. When intravitreal bevacizumab was added to supplemental laser treatment, now the cicatricial response was more intense than cases where intravitreal bevacizumab was added to the primary laser treatment. So the point here is that if you have established neovascularization and it's quite extensive, you might get resolution of the neovascularization, but you get more traction, which of course is a concern. So based on that, it would seem more fruitful to use bevacizumab in much earlier stages of the disease. But fortunately, there was no retinal detachment in all cases. So if we look at the current role of intravitreal bevacizumab in ROP, it prevents progression to stage 3 in high-risk cases, such as zone 1 or posterior zone 2 with plus disease. So I think there is a role now for injecting bevacizumab in zone 1 disease even before the occurrence of neovascularization, because we know that in zone 1 disease there is such a huge VEGF load that if we wait, we're definitely going to get neovascularization. If we inject bevacizumab very early, then it will blunt this VEGF response and might get the patient through without developing neovascularization. It will accelerate the resolution of stage 3 disease, possibly without laser. And of course, this is the rationale of the BEAT ROP study, which has really changed the nature of the game now. I think there are many surgeons all over the world who are now shifting to monotherapy with bevacizumab, even without the use of laser. And as we said, bevacizumab is better avoided in cases with established and extensive stage 3 disease, as this might increase the intensity of the psychotritial response. And I thank you very much for your attention.
We thank you very much for your nice illustration. I would like to call Dr. Sharif Hagazi to give his presentation.
Distinguished Chairman, ladies and gentlemen, today I'd like to show the results of our pilot study investigating intravitreal diclofenac use versus intravitreal triamcinolone for treatment of diabetic macular edema. This is a case that's easily diagnosed as diffuse DME, however it's more tricky to treat. Treatment options are abandoned. They include grid laser using anti-VEGF agents such as Lucentis and Avastin, using steroids. In refractory cases, we may revert to use post-planar vitrectomy, possibly with an ILM peel. Recently, intravitreal implants have even been suggested to increase the duration of agents inside the vitreous cavity. We have many treatment options, and we get lost in the maze of treatment modalities. There's no correct way or single way to follow in the treatment of DME. Steroids have been suggested among the most potent agents for treatment of DME, as they affect both pathways, the angiogenesis and inflammatory elements of this disease. They're very effective, however, they're very limited by the high incidence of complications, especially refractory glaucoma and the inevitable cataract. Their effect is also short-lived. This problem has been partially resolved by using intravitreal implants. What we need is an alternative. We need an agent that has a safer side effect profile and affects both angiogenic and inflammatory pathways responsible for the development of DME. Preferably, it will be cheap and available. So we thought of using diclofenac sodium as an intravitreal agent and compared our results against the well-established triamcinolone for treatment of DME that is not amenable to focal and or grid laser photocoagulation. After obtaining ethical committee approval of both the Research Institute of Ophthalmology and Cairo University, we began a prospective, non-randomized, controlled, open-label interventional study, which is currently in progress. To date, we have injected 20 patients with triamcinolone, and 6 patients have received intravitreal diclofenac sodium 500 micrograms with at least 1 month of follow-up. We included diabetics type 1 and 2 who have established DME with an OCT thickness that is at least 400 microns with best-corrected visual acuity that is equal or less than 0.2. We excluded patients who have any condition that may lead to increased DME, such as uveitis, macular pucker, VNT syndrome, or unstable glycemic or blood pressure. We also included any patient who had previous treatment for DME in the preceding 3 months or is expected to need PRP within 6 months of enrollment. Our results show that the patient selection was a little bit biased in selecting patients with worse vision and worse prognosis in the diclofenac sodium. We have to remember this is an off-label use of a drug, so we're a little bit cautious. Our mean preoperative visual acuity log-MAR values of 0.88 an average in the triamcinolone group versus a much worse 1.22 in the diclofenac sodium group. The mean preoperative central macular thickness in the triamcinolone group was a little bit better, with 500 microns versus 569 in the diclofenac sodium group. The mean preoperative IOP were equally, at least. So our results show that after 1 month in the triamcinolone group, we had an improvement from 500 microns to approximately 300 microns, showing an impressive 40% reduction. Diclofenac sodium behaved equally impressive, decreasing central macular thickness from 570 to 444 microns in just 1 month, showing a very impressive 22% reduction. You have to remember, we chose the worst vision, worst seeing patients with the thicker macula for diclofenac sodium group. This is an illustration of 2 patients that behaved favorably in the diclofenac sodium group. The first of whom had diffuse diabetic macular edema with a thickness of 640. This patient had a type 2 diabetes for the last 14 years, had a vision of 260. After 1 month of treatment, we can see that the macular edema resolved nicely, decreasing to 415, showing a very impressive 35% reduction in the central macular thickness. However, vision improved only to 460. Another patient who behaved even much better, a female lady who had diabetes for the last 7 years and a macular thickness of 536, giving her a bad vision of 360. After 1 month, we had an impressive 57% improvement in the central macular thickness, decreasing the macular thickness to 230. However, vision didn't improve beyond 660. In conclusion, intravitreal diclofenac sodium caused a significant short-term reduction of the central foveal thickness. However, these results compared as being slightly inferior to the use of intravitreal triamcinolone. If this result is confirmed by longer follow-up, diclofenac sodium intravitreal injection may potentially serve as an alternative to triamcinolone oral treatment modality, especially if proven not to cause cataract and glaucoma, which we didn't see up to date. Thank you.
Thank you, Dr. Higazi. I would like to call Dr. Shuman to end his presentation.
I'm so sorry for the delay. I was talking about the visualizing aids in vitrectomy, which we said it was indocyanine green, triamcinolone, and trypan blue. Indocyanine was the first to be used with most success regarding the delineation and the visualization. I was getting this video about injecting it. It was proposed to be injected in fluid-filled eye with turning off the light of the microscope to decrease the photosensitization by the light and so decreasing the phototoxicity. This was suggested to decrease its bad effect on the retina and the rods and cones. And then we decreased the bolus of indocyanine green by aspiration And we regard the very good delineation of the ILM with a very good contrast between the area stained and the area which is not stained, which decreases the element of leaving any residual ILM behind. But of course, the bad thing about ICG that it was proven to damage the retinal pigment epithelium and the rods and cones, which I think almost nobody's using it right now. I stopped long time ago, of course, although it was very good in contrast. The second is the triamcinolone, which is a synthetic corticosteroid, which is 8 times stronger than prednisolone. It's used in many things in ophthalmology, as we all know. It's an adjunct to anti-VEGF treatment in AMD, of course, in diabetic macular edema, like Dr. Sharif Higazi has just mentioned, of course, in macular edema, secondary retinal vein occlusion, and a lot more, but these are to mention. The most important thing is in this video is to identify the posterior cortical vitreous, which is sometimes difficult to identify or to grasp at the starting point of vitrectomy, where we have to remove the posterior vitreous face totally with the least danger to the retina. Because if we are not visualizing, sometimes we get so near to the retina to attach it, and we can hit the retina or the optic nerve. As we all know, we usually aspirate at the nasal side, and we said yesterday in the institute we should be aspirating at the temporal side more, so it's rather dangerous. So using triamcinolone in this area increases our contrast and the ability to see the cortical vitreous. The second thing in proliferative diabetic retinopathy, where we usually have vitreous cases, splitting of the posterior vitreous face. So after removing a total layer of posterior vitreous face, you get a totally another layer. If I didn't inject triamcinolone, I wouldn't have seen this layer. It's almost a total membrane, as if you have removed nothing. And you should remove every bit of the posterior vitreous face as much as you can to decrease the probability of new vessels returning again into the eye. As we can see, it's a total sheet, as if you haven't removed, I have removed in this case, a total layer prior to this one. So I'm getting a totally another layer of posterior vitreous. Also in cases of myopic traction maculopathy, and in this case, there's an epiretinal membrane, very mild on the foveolar area. As we can see, I'm getting it with a fluid needle. I wasn't seeing it when I didn't inject triamcinolone. I couldn't see it. When I injected triamcinolone, I found it very prominent. Also in ILM peeling, it's not a staining, as we all know. It's just we inject it to get entangled on the surface of the posterior vitreous face, or to get precipitated on the surface of the ILM, so that when we are peeling, as you can see here, we get a difference in the color between the area denuded of the particles of the triamcinolone and the area with the triamcinolone on it, so that we can see what we are peeling and what was left and where we are heading with our peeling of the ILM. So it enhances our visualization. Although one of the drawbacks of triamcinolone is sometimes you leave behind parts of the ILM because you can't see them all. As I said, it's not a staining. But although it's very beneficial. The side effects, of course, that we know about triamcinolone, it's suggested that it gets trapped, the particles get trapped in the myopic hole sometimes, or in the macular hole, and theoretically reduce the chances for closure. Also, there is a suggestion that it increases the susceptibility to endophthalmitis. In addition, the intraocular pressure elevation post-operative almost at least 1 month to 3 months, and it's been proposed that some cases a percentage can end up by doing trabeculectomy or glaucoma surgery. Also, its cataractogenic effect if you are using it in phakic cases. The third is the trypan blue and the Brilliant blue, which I think most of us are using as vitreoretinal surgeons now. It has been used starting in phacoemulsification in mature cases to enhance the visualization of the anterior capsule. It has been proven to be cytotoxic, although in the very minute concentrations, the effect is minimal, so it's been used till now. The formulation that we're using for the posterior segment is 0.15 to 0.18%. by different companies. The one used for the anterior segment is 0.06%. So 0.15% is increase in the concentration to enhance the visualization of the ILM. Of course, it's used in epiretinal membrane, in posterior vitreous retinal membrane identification, ILM peeling, and posterior vitreous face identification. The membrane blue or the trypan blue better stains the epiretinal membrane as it stains the dead tissue better. So it's a better staining of the epiretinal membrane than the ILM. That's why brilliant blue has been introduced into the market where it can stain the ILM and the epiretinal membrane with the same effect. The other thing in brilliant blue and the newer membrane blue dual is that they are denser than water in density, so that they can be injected in a fluid-filled eye, not in air-filled eye, as we all do with our trypan blue. The ways to inject, of course, the one we are using is injecting it under air. We do fluid-air exchange, of course, inject a bolus of trypan blue, leave it for 30 to 60 seconds, and then remove it with fluid needle, irrigation, and then we start peeling of the ILM, as you can see. Of course, the delineation and the contrast between the area separated and the area where the ILM is still there is minimal. So you have to have good optics, the least corneal edema to get a good contrast. This also is a case with a residual ILM, which I wasn't seeing except when I injected trypan blue. The ways to inject eyes, as I said, under air or chill the dye in the fridge to get it heavier in density and inject it in a fluid-filled eye, or use the recent brilliant blue and the membrane dual, or dilute the dye with a 50% dextrose to get it heavier density and so precipitate it over the surface of the retina. Of course, the future of the dye, there are different dyes which are now proposed. These are part of them, the Patent Blue V and the Chicago Blue, bromiphenol blue and the green SF, and the rhodylene blau basic. No one has come to the market, as I know, till now. So we are stuck with the one that we have, which with a rate of success which I would count is very good. Thank you.
Thank you for your nice presentation. I may call Professor Ahmed Abdallah for his presentation, Incidence of Postoperative Epiretinal Membranes and Macular Pucker following vitrectomy in patients with penetrating ocular trauma. Dr. Ahmed Abdallah, please.
First of all, I would like to thank Dr. Ahab Rais for his generous invitation, and then I would like to ask you to pray for those who lost their lives in this Egyptian revolution, and to pray to bless, for God to bless those who sacrifice their eyes or part of their bodies. Today I'm going to talk about the incidence of post-operative epiretinal membranes and macular pucker following vitrectomy in patients with penetrating ocular trauma. Is it really the rule of tamponade or not? Penetrating trauma of gunshot injuries has a serious devastating ocular damage, either by mechanical tissue damage, either directly or by the shock waves, chemical effect as hidrosis bulbi, recurrent severe PVR, biological risk of infection, which is rare in gunshot injuries, immune response like sympathetic ophthalmitis due to retained intraocular foreign body or poor management, and this all leads to poor visual acuity, recurrent uveitis, persistent hypotony, cysts bulbi, and at the end, enucleation. So we have first to make primary repair adequately and giving anti-inflammatory and drugs that decrease fibroblastic activity, then vitrectomy for removal of media opacity, removal of circulating proliferative materials and mediators, reattachment of detached retina by relieving traction and sealing of brakes, and then introducing a tamponade. Talking about the tamponade, do we need silicone oil? Do we need gas? Silicone oil has a long-term effect as a tamponade, limits circulation of proliferative growth factors, and decrease tractional detachment, and helps in limiting a localized detachment, stabilizing hypotenuse eyes, and no contradiction with air travel shortly after surgery. But the drawbacks are recurrence after removal, glaucoma, cataract, and keratopathy, etc. Non-silicone oil tamponades like air, which is a short-acting tamponade, sulfur hexafluoride, perfluoropropane, perfluoromethane, perfluoroethane, and perfluoro-N-butane. The drawbacks are cataract, increased intraocular pressure, and the recurrence after disappearance of the gas bubble, and also it is contradiction for air travel after surgery. Regarding our study, it is a retrospective case study that included 70 eyes with gunshot injury. Pars plana vitrectomy was performed 2 to 3 weeks after primary repair, relieving the traction. Lensectomy either primarily or during the follow-up period if there is clinically visually significant cataract. Intraocular foreign body removed. PFC was used to stabilize the detached retina. Retinal incarceration was managed by retinectomy and mobilization. Subretinal hemorrhage was cleaned through a retinotomy if possible. Tamponades, either SF6 or 1,000 centistokes silicone oil. And these patients were reviewed at 3 weeks, 1 month, 2 months, 4 months, 6 months, 1 year, and 18 months till now. These patients were reviewed for mechanical insult, best corrected visual acuity, intraocular pressure, anatomical retinal attachment, macular pucker, and epiretinal membranes, number of interventions and timing of silicone oil removal. Patients with visually disturbing macular pucker during the follow-up period were operated by ILM peeling and application of a gas tamponade. These are some of the gunshots that we removed from the eyes. Those are examples. Some of the gunshots were very small and some of them were very large. Some eyes had multiple gunshots and some of them were in very difficult to place removes, like this one on the left. There was 2 billets, one inside the eye in the posterior compartment and one was under the iris, entangled within the venules. At the timing of removal of silicone oil, epiretinal membranes were managed by removing by forceps, and we can see also the site of the posterior exit, which is covered by a very dense membrane. Inferior epiretinal membranes were managed and removed by forceps. Reviewing the data of the patients, we can see that there is a high incidence of lensectomy in the silicone oil group that was 45.7% compared to 17.1%. There was a higher incidence of post-equatorial insult in the silicone oil group, which was 60% compared to 17.1%, sorry, 68.6% silicone oil group compared to 25.7%. There was higher incidence of retinal breaks in silicone oil group, which was 60% compared to 17.1%. Presence of retinal detachment was higher in the silicone oil group, which was 85.7% compared to 22.9%. Presence of subretinal hemorrhage was higher in the silicone oil group, which was 71.4% compared to 42.9%. Also, comparing the number of interventions, there were higher incidence of interventions, large number of interventions in the silicone oil group. That was, the mean was 1.54 plus or minus 0.657, compared to 1.17 plus or minus 0.382, which was highly significant, was higher intervention silicone oil group. Peripheral retinal membrane development was higher in the silicon oil group, which was 42.9% compared to 11.4%. Macular pucker development was higher in silicon oil group, which was 54.3% compared to 40% in the gas group. And this shows the incidence of post-equatorial damage was higher in the silicon oil group. Regarding best corrected visual acuity, we can notice that the best corrected visual acuity is much more higher in the gas group than the silicon oil group. Even after the silicon oil removal, there was a very high number, very high percentage in the area of 0.1 to 0.3 decimal, which was 51.4% silicon oil group compared to 34.3% in the gas group, and from 0.3 to 0.6 decimal was 2.9% compared to 37.1% in the gas group. More than 0.6 decimal was 5.7% in the gas group. This is a graph showing the higher best corrected visual acuity in the gas group. Regarding the sequelae, patients that needed 2 pars plana vitrectomy was 37.1% compared to 17.1% in the gas group, and patients that needed 2 pars plana interventions was 8.6% in silicon oil group compared to 0% in the gas group. Number of patients with persistent hypotony was higher in the silicon oil group, 14.3% compared to 5.7% in the gas group. Number of patients with keratopathy was higher in the silicon oil group, 5.7% compared to 2.9% in the gas group. So the take-home message that gunshot injury has a very devastating anatomical and functional incidence to the globe. There is a higher incidence of formation of inferior retinal membranes with silicon oil tamponade. Is this related really to the tamponade or the severity of damage? This is a question to think about. But my opinion that silicon oil group makes, you never can fill the globe with silicon oils, that always you have a fluid meniscus, that all the proliferative materials are concentrated in this fluid meniscus, helping in the formation of the very dense and tough membranes. That's my own opinion. And damage to the post-equatorial tissues increases the risk of visual and functional damage and the incidence of complication. Thank you.
Thank you, Dr. Abdallah. So we will end the first symposium with a coffee break, and we will like to ask you that you, at 11 o'clock, we'll start our opening ceremony. Thank you.